Welcome to an extended special edition of the Public Health Practice Gap. I am your host, Dr. Fevrier, founder of NextGen Public Health Consultancy. Over the last 3 episodes, we have been deconstructing the invisible forces that govern population health. We have explored empathy, the radical act of understanding another human's experience. We have examined the trust recession and how institutional legitimacy crumbles from the inside out. And last week, we dissected the belonging deficit, highlighting how connection and true belonging are fundamentally different things. In today's episode, we are bringing all of these concepts together into one unified theory. I believe public health is entering a fundamentally new era. For the last century, our greatest challenges were technological, biological, and physical. We needed better vaccines, cleaner water, and safer roads. But today, the greatest challenge facing our field is no longer technological. It is relational. Today, we are talking about human infrastructure. What if the future of public health doesn't depend primarily on hospitals? Take a moment to truly sit with this question. If I ask the average person, or even the average policymaker, to define the health infrastructure of a city, they will immediately point to the physical assets. They point to the level 1 trauma center downtown. They point to the specialized clinics, the supply chains of pharmaceuticals, and the MRI machines. But what if that is just the crisis response infrastructure? What if the actual health infrastructure, the systems that keep people from needing the trauma center in the first place, is something much larger, much older, and currently much more fragile? I am talking about the relationships, the communities, the civic institutions, and the trust networks that make healthy societies possible. We have spent trillions of dollars optimizing the physical infrastructure of healthcare, but we have completely neglected the human infrastructure. As a result, our physical systems are buckling under the weight of a society that is fundamentally lonely, burnt out, and disconnected. Grab a notebook and settle in. Over the next few minutes, we are going to redefine what infrastructure means in the 21st century. To understand where we are going, we have to look at where public health comes from. The entire foundation of our discipline is built on the realization that infrastructure changes behavior. In the mid-19th century, during the devastation of the cholera outbreaks in London, the prevailing medical theory was miasma, the idea that bad air caused disease. It wasn't until Dr. John Snow mapped the outbreaks and traced them to the Broad Street water pump that the paradigm shifted. Snow didn't try to change individual behavior by passing out flyers telling people to boil their water, etc. He removed the pump's handle. He changed the physical infrastructure. Fast forward to the 20th century. We didn't reduce traffic fatalities simply by asking people to drive better. We engineered the physical environment. We built divided highways, mandated seatbelts, and installed shatterproof glass. We changed the infrastructure. The lesson of public health history is that individual behavior or interventions have severe limits. You cannot out-educate a toxic environment. If you want to change population health outcomes at scale, you must build systems that make the healthy choice the default choice. Infrastructure is the silent architect of human behavior. We are magnificent at building physical infrastructure. Our water is clean, our buildings are safe, our emergency response times are heavily optimized. But we are now facing a completely different class of disease. Look at the defining public health crisis of our current decade. An epidemic of chronic loneliness and isolation, systemic multi-industry workforce burnout, deep societal polarization, and political fracturing. pervasive distrust in the medical and scientific institutions, deaths and of despair, and including rising rates of substance use and suicide. You cannot solve a crisis of disconnection by building a better highway. You cannot cure burnout by upgrading the software in a hospital. You cannot build trust by erecting a new clinic. These are not physical infrastructure failures. They are human infrastructure failures. The mortar holding society together is dissolving. People are retreating into highly curated algorithmic silos. The physical world is intact, but the psychological and relational world is deeply fractured. We are living in a society with flawless broadband connection, but zero human bandwidth. We are going to dive into the 4 specific pillars of human infrastructure next, and exactly how we rebuild them. But first, I want to take a brief pause. Transferring these massive concepts into operational, on-the-ground reality is exactly what we do at Next-Gen Public Health Consultancy. If you are a healthcare leader, an academic advisor, or a community director trying to figure out how to navigate these relational challenges within your own organization, we need to connect. We translate these exact system-level thinking into real-world strategic frameworks. To learn more about our organizational consulting and to make sure you never miss out on an analysis, subscribe to our weekly newsletter, the Next Gen Public Health Brief. You can find the archives and subscribe directly at nextgenpublichealthconsultancy.com. Let's get back to the breakdown. If we are going to treat human relationships as infrastructure, we need an engineering schematic. Human infrastructure is built on 4 load-bearing pillars. If any one of these fail, the infrastructure collapses. 1. Empathy. Understanding human experience. Empathy is the diagnostic tool of human infrastructure. It is not about simply feeling sorry for someone. It is the cognitive and emotional capacity to deeply understand the context of another human's perception or decisions. Without empathy, public health becomes a series of rigid mandates issued from an ivory tower, completely disconnected from the lived reality of the community. 2. Trust, which is confidence in institutions and relationships. As we discussed in episode 18, trust is the currency of public health. It is the psychological safety required for vulnerability. If people do not trust the institutions delivering the message, the scientific validity of the message is completely irrelevant. Trust is what allows systems to function efficiently without requiring coercive force. 3. Belonging, feeling connected and valued. From episode 19, we know that belonging is the realization that you are needed. It is the protective factor that anchors individuals to the world. A society with a high sense of belonging is highly resilient to trauma. A society with belonging deficits self-medicate through consumption, addiction, and tribalism. And fourthly, community, networks that sustain resilience. Community is the structural embodiment of the first 3 pillars. It is the web of strong and weak ties that catch people when they fall. True community is geographically and operationally bound, requires mutual obligation, and serves as the ultimate preventive health intervention. We cannot have a conversation about the future of public health without addressing the elephant in the room: artificial intelligence and digital technology. Can technology strengthen these 4 pillars? The short answer is yes, but only as a highly targeted tool, never as a replacement. Technology is incredibly useful for logistical scaling, can analyze epidemiological trends, optimize supply chains, and remove administrative burdens so that public health professionals have more to spend with patients and communities. But we must be fiercely protective over what I call the illusion of scale. There is a dangerous movement within modern tech to automate empathy. We see it in AI-driven therapy bots, automated HR wellness checks, and algorithmic patient care communications. This is a catastrophic misunderstanding of human psychology. You cannot automate empathy because the healing power of empathy comes from the cost it requires of the person giving it. It means something because a real human being is taking the time and emotional energy to sit with you. Furthermore, we are suffering from the death of social friction. We have used technology to make everything seamless. You can order groceries, work, and consume media without ever speaking to a neighbor. But social friction, the small talk at the grocery store, the negotiation of shared space, the brief interactions with acquaintances, is the daily exercise that builds human infrastructure. When we eliminate all friction in the name of efficiency, we atrophy our capacity for community. Technology cannot build human infrastructure. It can only facilitate the humans who do. So what does investment in human infrastructure actually look like in the real world? It requires a radical shift in how our major institutions view their roles. For our employers, we must start viewing the workplace as a critical health infrastructure. It is where adults spend the majority of their working lives. Investing in human infrastructure here doesn't mean offering a meditation app or a yoga Friday. It means designing workflows that do not intrinsically burn out people. It means training managers in psychological safety and prioritizing systemic rest as a non-negotiable operational metric. For healthcare systems, it means moving away from the hyper-commodification of the patient encounter. It means adjusting reimbursement models so that primary care physicians actually have the time to build a trusted relationship with a patient rather than rushing through a 7-minute algorithmic check. For schools and communities, it means funding shared physical spaces, libraries, parks, community centers, and food spaces, not as luxury civic amenities, but a primary health prevention hub. It means valuing the school counselor and the community organizer as highly as the epidemiologist. This brings us to the ultimate practice gap. The greatest challenge facing public health today is not a lack of scientific evidence. We know how the body works. We know what causes chronic disease. We know how viruses spread. Our gap is no longer simply between knowledge and action. The gap we have fallen into is the chasm between efficiency and humanity. We have designed our systems, our workplaces, and our educational institutions to be perfectly efficient machines, and we are shocked when they fail the human beings inside of them. We are trying to solve relational deficits with informational patches. Strong societies are not built solely on technology. They are not built on perfectly optimized spreadsheets or automated workflows. They are built on trust. They are built on belonging. They are built on community. They are built on empathy. They are built on human infrastructure. If we want to move the needle on the modern crisis of isolation, chronic disease, and burnout, we have to stop treating these relational elements as soft skills. They are the foundation, and rebuilding that foundation is the next great frontier of public health. If you have enjoyed this 4-part series on empathy, trust, belonging, and infrastructure, I encourage you to take this work into your own organization. To help you do that, subscribe to the Next Gen Public Health Brief at nextgenpublichealthconsultancy.com. New episodes of this podcast is released every Tuesday. Take care of yourselves and take care of the people around you. I am your host, Dr. Bradley Fevrier, and this has been Public Health Practice Gap.